we're pleased to have this forum. We host it every year, so thank you for joining us to learn more about what to expect with Maryland's upcoming legislative session. If any of you are like me and you've been following the local political news, you may have noticed that there have been some changes with leadership within the General Assembly, specifically within the House of Delegates. We have a new Speaker of the House in the House of Delegates, Speaker Jocelyn Peña-Melnick. She is a Democrat from Prince George's County and Anne Arundel counties, and she was elected to that position in December. In taking on that role, she has announced a number of leadership changes and structural changes within the House that's going to change how we as behavioral health advocates approach our work this coming session and in the future. Session begins on January 14th, as some of you already know. Some of the changes, though, I just wanted to highlight within the House. They represent some pretty significant shakeup within the House Democratic Caucus's leadership structure. We have 5 new committee chairs and numerous new vice chairs. So many people are moving into new leadership roles. But the most notable for behavioral health advocates is that the former Health and Government Operations Committee, or HGO, I don't know how I'm going to stop calling it that, but that was split into 2 committees. So now health has its own committee. It'll be focused just on health issues. That is where we expect many of our behavioral health legislations to be heard in the House this session. That new health committee is chaired by Delegate Heather Bagnell and vice chaired by Bonnie Collison, who was the former vice chair of HGO. Both have served on HGO for a long time, so they know our work. They know BHSB, they know behavioral health. So that's all positive. But the overall changes within the House are going to mean new dynamics and new things that'll be happening as we approach our advocacy work this session. On the Senate side, not a whole lot of change going on. Senator Bill Ferguson, who represents Baltimore City, still leads the Senate, and how the Senate and the House leadership are going to work together will also be new. So it'll again be new dynamics and new ways to approach our collective work together. One thing just to highlight early on, and you'll hear about this more from our speakers in a moment, a challenge that we already know is forthcoming this legislative session is that the legislature is going to need to be closing a nearly $1.6 billion budget gap for FY27. So this was a problem we all addressed and worked together on last session. It was a bit of a bigger number last session. This one's a little smaller. The thing to highlight, not for now, but will be kind of looming as we are having all these budget discussions, is that Maryland has a structural deficit. So that means beyond this year, right? So that means in future fiscal years, the budget gap is larger, and we don't have a long-term plan for how to address that. But this budget gap is going to mean that we are going to have to be navigating that. The issues that will be key during session and central to any, it'll be central to any policy considerations, especially as we're thinking about asking for increases, especially as we're looking at new initiatives. Reimbursement rates for development of disabilities and behavioral health care are some of the largest reasons we have this deficiency within the state budget. For behavioral health, the reason for that is that there was a larger than anticipated service utilization of Medicaid services. Not necessarily a bad thing, right? It's showing that people need care and they're getting access. It just means the state didn't anticipate all of that need. At the same time, the General Assembly will need to address health policy changes as a result of federal changes, or a bill that Congress passed. You may have heard the big, beautiful bill. Some of those changes are already in effect. We have Medicaid here with us today, and they're going to go into more detail on what that means and what Maryland can expect with those changes. But for behavioral health, the most significant changes will be managing those to the Medicaid program. And again, we'll talk about those in a bit more detail. So these are the challenges. These are the things that are ahead of us this session. We've got a great group of speakers here who are going to go into this in a bit more detail. But I just want to say that we as advocates, we've been here before. We know what's ahead of us. And it's amongst all of us to work together to address these issues. So without further ado, I'd love to turn it over to our panelists today. Some of them I hope are familiar to you. First, joining us is Dan Rabbit, BHSB's policy director, After Dan, we'll hear from Alyssa Brown, who's the director from the Office of Innovation, Research, and Development at Maryland Medicaid. And then finally, closing us out, we'll have Nicole Grainer, Director of Government Affairs and Public Policy at the Community Behavioral Health Association of Maryland. And then finally, just as a reminder, please hold your questions till the end. We'll have time for question and answer at the end. So without that, I'm going to turn it over to Dan. Take it away, Dan.
Thanks, Adrienne. Good morning, everyone. Great to be here with you, and Happy New Year. We have an exciting year ahead. I'll leave it at that. Like Adrienne said, session starts soon, and what I wanted to go over is the priorities that Behavioral Health System Baltimore has developed for this coming session, as well as into the following year. We develop 2-year policy priorities every 2 years, and we really like to conduct a whole lot of community engagement and community outreach to hear from residents of Baltimore and our partners across the state about what is most concerning or important to them. And this year's process was similar. We had a digital survey that we put out that we had almost 200 responses, and we conducted 11 interviews and kind of took all the information that we received to identify our priorities for the next 2 years. Next slide, please. And so I wanted to go over those and then comment a little bit on how we think these different priorities might play out this session coming up. Our number one priority for the year is to promote high-quality behavioral health services. We have heard from community members, from local officials, from the provider community themselves that driving high quality, improving quality, holding providers who are potentially providing less high quality services accountable is crucially important. And we expect that to remain top of mind for state leaders, local leaders, and we're going to be looking for opportunities to drive that forward in the years to come. So that was priority number one. Number two here is to ensure that Marylanders retain a full access to a full range of behavioral health services through Medicaid. We'll hear a lot more from Maryland Medicaid a little bit later, and we're really grateful to have them here with us. But this is essential. Medicaid is the largest source of funding for behavioral health services and covers about a quarter of all Marylanders, providing health coverage to them. So incredibly important to keep the Maryland Medicaid program as strong as possible. Our next policy priority is to strengthen and expand in the behavioral health workforce. This has been a priority of ours for a number of years, and unfortunately, the issue remains. There was a really important and insightful report that was issued, I think 2 years ago now, by the Maryland Healthcare Commission that identified the big gap in the available behavioral health workforce in the state's needs. Not a lot of those recommendations have been acted upon. And so increasing rates and funding to providers to hire, to offer competitive salaries, while also looking to other initiatives and reforms to licensure and certification remains a really important priority for the state. Next slide. Excuse me. These next three priorities are actually relatively new on our docket. Increasing affordable housing options. This was actually the number one priority that the community shared with us through our survey and engagement. And affordable housing is the number one basic need that folks have. And we've also seen a lot of threats coming in from the federal government around permanent supportive housing. The current federal administration doesn't seem to believe in that model. And so increasing and protecting affordable housing is going to be a priority of ours in the next 2 years. Implementing policies to reduce law enforcement and criminal justice interaction is our fifth priority. This can be accomplished in a number of ways. We're going to continue to support crisis services as an alternative to law enforcement, but also looking at other ways to reduce justice involvement will be important to this priority. And lastly, we want to maximize the impact of state and local opioid restitution funds. The state has significant resources, and Baltimore City has even more. And so we want to partner with the state and with the city and look to potential policies that could advance the impact of those resources, such as harm reduction services, overdose prevention sites, and recovery supports to make sure we make the most of this opportunity that these resources provide. So those are our 6 priorities. Next slide. The way we see this playing out in 2026 is we expect the General Assembly to be taking on issues related to the One Big Beautiful Bill Act, OBA, as our friends at Medicaid call it. But that does contain a number of issues. Medicaid is the most important for behavioral health, but there's a number of tax and revenue changes that this federal law um, will affect our state revenue as well. And so we expect the General Assembly to maybe take up some of those issues as well as the changes to SNAP. We expect behavioral health care reimbursement rates and funding overall to be a really top priority, as Adrian mentioned at the top. Behavioral health spending has contributed to our higher than anticipated budget deficit. It's not, that's really more of an accounting thing that the folks at DLS expected a certain amount and there was more. And like Adrian mentioned, that's not necessarily bad, that those are people accessing services, but we expect that to be an issue that we will have to respond to. Certified community behavioral health clinics is a really innovative and high quality model that we expect to be discussed. And our partner, Nicole at CBH, is going to share more about that later. Ongoing quality initiatives are hopefully some new quality initiatives, and the ongoing regulatory revision is certainly going to be in the mix this year. There's a number of workforce licensing and certification bills, some that didn't get over the finish line last year, and we expect some potentially new ones. We think that this is another important component in addition to funding that can help address our behavioral health workforce shortage. And then overdose prevention and harm reduction is always really important to BHSB. We're not sure exactly what bills will be in this bucket, but we are sure that this will be an issue. We're really excited that Jocelyn Pena-Melnick, our new speaker, it has risen to that position as she has been a really big supporter of overdose prevention and harm reduction. She has been the House sponsor for the overdose prevention site bill for a number of years. So those are some of the issues that we expect this year. Next slide, please. And lastly, just to give you guys a quick cheat sheet for those who want to like follow along with us, the General Assembly, the session really is driven by certain deadlines. And so the Assembly convenes a week from today, and then the governor's budget will be introduced by 2 weeks from today. That budget will really give us an indication of where we stand in the behavioral health sector. The bill introduction deadlines are the next big kind of set of deadlines, and those are in early-ish February. By that time, you'll start seeing a lot of bill hearings, and kind of the majority of the bills that we can anticipate will be introduced by that time. And then crossover is March 23rd, and that's a huge deadline by which most bills that are going to be successful need to cross over from one chamber to the next. And adjournment is April 13th. So we'll be sending out information through our policy alerts and social media, but those are just some key deadlines for folks at home to consider if you're hoping to track and follow along and be active this session.
Thanks, Dan.
Mm-hmm.
All right, so hopefully by now you've got an idea of what we at BHSB are going to be focused on in 2026. Now, I'd love to turn it over to Alyssa Brown, who's going to go into more detail on the Medicaid issues. And so you've got your screen up, so I'm going to turn it over to you, Alyssa.
Thanks so much, Adrienne, and thanks so much for having me today. I am looking forward to presenting to you on some of, as Dan mentioned, we call it OBA at the department. I know it has a number of different names it's going by these days, but some of the major provisions of OBA and their expected impacts on Medicaid, as well, just briefly, some of the planning activities the department's engaged in to be responsive to these changes. Next slide, please. So I'm not going to kind of belabor the first few slides in the deck too far, but obviously OBA is expected to have a significant impact on Medicaid's operations. As many as 175,000 Marylanders may lose coverage as a result of these changes, and I'll dive into a little bit deeper insights on that in a few minutes. But there's also expected to be a significant fiscal impact just as a result of the loss of federal funding, not only tied to the eligibility changes, potentially as much as $1.4 billion in federal funds, but a total of $2.7 billion losses overall once all provisions of the bill are implemented as a result of changes to provider taxes and some of the other components of the bill. Next slide, please. So mitigating some of the risks associated with these losses obviously is going to require some significant impacts, both from a planning perspective as well as administratively in terms of some of our data systems, as well as staffing. Next slide, please. Next slide. So before we jump into some of the specific provisions of OBA, I did want to just give some insight in terms of how the department is approaching this from a problem-solving perspective. Our key objective in all of this is to protect healthcare coverage for eligible Marylanders, consistent with federal law and guidance. Although this is very different than on the public health emergency unwinding, much of the infrastructure that we had put in place around that planning, we've stood back up to be responsive to the OBA changes. So that includes work streams focused on communications, data and systems changes, and then staffing. And then you see foundational to all of this are our advanced planning documents. If our 1115 waiver and our state plan are key to getting authority from the Centers for Medicare and Medicaid Services for the benefits that we cover, advanced planning documents are a crucial element for getting authorization from CMS for some of the expenditures we know that we'll have to undertake to come into compliance. Next slide, please. And just to give you a sense of kind of the breadth of scope, this is a real full court press across really not just MDH, but other agencies as well. We're working in partnership with the Maryland Health Benefits Exchange, DHS, Maryland Benefits, CRISP, MHCC, as well as external stakeholders in our managed care organizations. And I expect, particularly around communications, right, that external stakeholders piece is going to continue to grow. But I did want to just give you at a glance a sense of just how many different agencies are coordinating around these different work streams. And I'm currently in, somewhere between, 6 to a dozen meetings a week around planning process across these different work streams. Next slide, please. So the next few slides dive into some of the specific changes that OBA requires. So one of the critical ones that comes into play first is effective October 1st of 2026, which was requiring certain changes around immigration status in individuals who will qualify for Medicaid. Specifically, refugees, asylees, immigrants granted parole for at least 1 year, and certain victims of abuse and trafficking will no longer be eligible for Medicaid by and large. There are certain provisions in the final legislation, however, that do not apply this change to individuals who are pregnant or children. So we'll continue to cover the individuals in all immigration statuses that are eligible today for individuals that are pregnant or children. It's a critical component here. A lot of the changes under OBA primarily affect just adults. And one other question that we've been fielding frequently on the department side is whether the changes to immigration status through OBA will impact the Healthy Babies program that currently covers individuals who have an immigration status that would otherwise render them categorically ineligible for Medicaid. That program has been in place since July of 2023. That program is not impacted. You may also be aware that we cover emergency Medicaid services for individuals that would not otherwise qualify for Medicaid based on immigration status. Those provisions are not impacted either. So both of those programs will continue. I think, in some respects, that means that the emergency Medicaid program in particular can serve as a safety net as of last resort for some individuals that may be losing coverage. Next slide, please. In terms of work requirements, I have a few different slides on this one. So we'll do a deeper dive in terms of some of the expected impacts, but this provision will come into play on January 1st of 2027. I want to be really clear on this because this is going to be something that we are trying to really hit hard in some of our communication strategies coming online later this year. But work requirements are going to impact only adults ages 19 through 64 who are covered through the Affordable Care Act Medicaid expansion. So they do not apply to all adults enrolled in Medicaid, just ACA adults. So that means about 320,000 people who are enrolled in coverage today will be impacted by those changes. As we've seen from other states that voluntarily took this up through 1115 waivers and otherwise, there's a significant administrative burden anticipated associated with standing up system changes and needed staffing expansions. So just flagging that this is going to be a significant lift for the department. Next slide, please. There's also changes that will impact eligibility with respect to access to retroactive coverage. So under our existing coverage today, we cover up to 3 months of retroactive Medicaid coverage. OBA is going to change that in 2 key ways. And the way that it'll change coverage is different for those 320,000 ACA expansion adults compared to all of our other enrollees. So for the ACA expansion group, that will be limiting retro to 1 month, a 1 month period, whereas all of our other enrollees will be limited to 2 months of retroactive coverage rather than the 3 months available today. We do expect a fiscal impact of an estimated $3.1 million in federal funding each year as a result of these changes. And of course, uncompensated care is expected to increase. And those changes also come online at the same time as the work requirements. The other big hitter that is obviously on our radar and thinking about how it will impact access to care are changes. Next slide, please. All right, great. Our changes to renewals. And this is, again, a change that impacts just the ACA expansion adults, so those 320,000 adults, where today we have a 12-month renewal cycle. Those individuals will be shifted to a cycle where they have to come into be renewing their benefits every 6 months. So that means they'll be held to 2 new standards as a result of these changes, both compliance with work requirements and having to come in and renew their benefits on an every 6-month basis. Obviously, making investments from a systems perspective to do new data matches, help try to increase our ex parte renewal rates, as well as communicating to the public about expectations. And this shift is going to be critical to help mitigate coverage losses. Next slide, please. I won't get into these in too much detail, but there are a number of other provisions in OBA that are expected to impact Medicaid. Specifically, changes in provider taxes may impact our ability to draw down certain federal funds. And there's also changes expected around budget neutrality, which may impact our Medicaid demonstration that we're currently in the process of negotiating with CMS on for a renewal effective January 1st, 2027. And I did want to flag, there's also a provision subjecting the department to potential increased risks around audits in the future. So making sure our systems are kind of watertight will be critical to help mitigate potential fiscal risks in future years. Next slide, please. Adrian, I don't think I have time to kind of jump into all of the details on the work requirements, but I defer to you in terms of the level of detail you want me to address here. But there are a number of different ways that people can meet work requirements when those go into effect on January 1st. You can see some of those listed here. And I did want to flag that there are a number of, next slide, please, exemptions from these requirements, including for individuals participating in substance use disorder programs, and probably of greatest interest to those on the call today for individuals who qualify as being medically frail. Next slide, please. And you can see on this slide some of the broad categories that are included in statute in terms of how individuals can be considered medically frail. That includes being blind or disabled, having a substance use disorder or disabling mental disorder, having certain physical, intellectual, or developmental disabilities, or serious or complex medical conditions. Next slide, please. And so the department is taking a lot of time in terms of reviewing how to best implement this requirement. We're working closely with CRISP to try to assess ways to automatically verify if someone might have one of these conditions. States to date, based on guidance from CMS, have discretion in terms of how to scope medical frailty definitions based on existing CMS guidance issued during around the initiation of the Affordable Care Act. So there are some opportunities here to exempt individuals, particularly with substance use disorder and certain mental health conditions. But the challenge in all of this from an implementation perspective remains that CMS, at least under statute, is not obligated to release guidance until later this year, I believe in June of 2026. So it puts us in a place from a planning perspective where there's a lot of moving targets. So Meredith, if you can go ahead and bring us to the last slide. I will be sharing these with BHSB after today's call, but I did want to just flag, we'll go back to resources, please, that we do have a number of public resources available on some of the changes expected from OBA, including a new dashboard that breaks out expected impacts for ACA adults on a county and congressional district basis. So a lot of work that is yet to come. Obviously, we've been in a planning process since the bill passed and are going to be initiating a communication strategy over the course of 2026 to help reach our members both on a broad basis and with individualized outreach. And it'll be critical to have partnership from community providers who have that trusted relationship with our members to make that a success. So Adrienne, I'll turn things back to you, and I look forward to questions from the group at the end.
Thank you, Elsa. So thank you for providing all of that detailed information. As you all can see, there's a lot of change coming to Maryland Medicaid as a result of HR 1. And we know as behavioral health advocates that the policy changes that came out of that legislation aren't actually going to help to make our communities and our people healthier. However, I do think Alyssa ended on a really good note. This is the planning that we need to do as a state and as a community to make sure that people do continue to have access to their Medicaid healthcare coverage. So please partner with the department. Please engage with them. We'll make sure that we share those resources that Alyssa shared on her last slide so that you can remain informed. But as you can see, they have a lot of planning to do over the next 6 months and a year to begin to implement these changes. So it'll be important for us all to continue to be engaged with Maryland Medicaid and certainly support them during the legislative session with whatever resources and policy tools that they might need to help implement these changes. So with that, I'm going to turn it over to our next speaker, Nicole, who I believe is also with us. Nicole,
I am here.
There you are.
And I think I'm sharing my screen.
You are sharing your screen.
Perfect. Thanks, Adrienne, and good morning, everyone. And thank you so much for being here today. Happy New Year to you all. For those of you I have not yet had the pleasure of meeting, my name is Nicole Grainer, as Adrienne said, and I am the Director of Government Affairs and Public Policy with the Community Behavioral Health Association of Maryland. I've been tasked today to speak for a few minutes about three sort of connected issues that we see consistently coming up in our conversations with legislators and policymakers. Some of them have already been discussed, so I think what I'm to do is sort of go in with a little more detail. And those are going to include reimbursement rates, workforce challenges, and what quality and access actually look like in practice in Maryland's behavioral health system. So as I said, these are issues that show up in budgets, in legislation, and really ultimately in whether people can get the care that they need when they need that. But if you'll bear with me, just before I get into that, I want to spend just a minute talking with you about CBH, who we are and who we represent. I know we have a couple of our members on the call today, and thank you guys so much for your membership. Your membership helps us do the work that we do, so we do so appreciate you. But for anyone who may not be familiar with CBH, we are a membership-driven trade association, and we represent community-based behavioral health providers all across the state of Maryland. And our members deliver mental health and substance use disorder services in every region of the state and cover the full continuum of care. And that includes things like crisis response, intensive in-home services, outpatient, residential care, and certified community behavioral health clinics, or CCBHCs. And that breadth really matters because policy decisions don't land on one program or one provider. They really ripple across the entire system, and they affect access to services, they affect workforce stability, and the quality of care that people actually receive. It also means that when we talk about behavioral health, we're not talking about a single service or a single setting. We're talking about a system that people rely on at very different points in their lives. And that perspective is what shapes how CBH engages in policy and budget discussions in Annapolis. So our role is really to support providers and frankly the broader behavioral health system through policy analysis, budget advocacy, and systems level work. And we work closely with state agencies like Medicaid and MDH and BHA and partners like BHSB and legislators to translate what's happening on the ground into policy conversations. And a big part of that for us is making sure that policymakers understand the operational impact of decisions that might otherwise feel abstract. For example, how a rate decision affects your staffing patterns, how a regulatory change may affect access to care, and how all of that combines to affect quality. And one of the most persistent issues that we work on year after year, frankly, long before I got here and probably long after I leave, is reimbursement. So I want to spend a few minutes talking about our rates because really that for me is the foundation on which everything else rests. So in behavioral health, our reimbursement is structured very differently from much of the rest of the healthcare sectors. Unlike hospitals and managed care organizations, our rates are not automatically adjusted for inflation or rising costs. Our increases are not baked into our formula. Our rates only change if they're included in the governor's final budget and passed by the General Assembly. And that means that even in years with significant budget pressure, like Adrian talked about today, we're looking at a what'd you say, Adrian, $6 billion. Providers still have to come back and ask for money because if we don't ask, we don't get it. And even when we do, it's not guaranteed that we're going to get it. And I think last year is a really good example of that. In the governor's first budget, we were thrilled to see that he included a 1% behavioral rate increase. But as the conversations continued, as the pressure continued to mount, what we saw was in his second supplemental budget, that increase was removed and behavioral health was flat funded. So we got no increases, we got no cuts. And when we're looking at billion-dollar structural deficits, flat funding sounds kind of neutral, but frankly, it isn't. Flat funding means providers are absorbing higher costs with the same dollars. Their rents go up, utility prices go up, insurance goes up, compliance and administration costs increase, and providers don't have the ability to simply shift those costs somewhere else. They can't raise their prices, they can't limit who walks through their door, and yet they're still expected to meet regulatory, reporting, and quality standards. And when providers absorb those costs, that impact shows up almost immediately in staffing, access to care, and quality of services. They have to make decisions about hours of operation, staffing levels, caseload sizes, and frankly, which services can realistically be sustained, even as the community need continues to grow. And this isn't theoretical, my friends. For nearly 2 decades, 20 years, Maryland's public behavioral health system was essentially flat funded. And over time, that pushed the system to the brink of collapse. In 2016, the Keep the Door Open effort and the HOPE Act were deliberate interventions by the General Assembly to pull behavioral health out of financial crisis. Those mandated increases that followed, they didn't create a windfall for providers. What they did was begin to stabilize a system that was close to collapse. Those increases helped providers retain staff, reopen programs that were on the verge of closure, and begin rebuilding capacity. But they did not fully erase the decades of underinvestment. And those mandates are now gone. And the fact that providers have to ask every year doesn't mean that the need has gone away. It means that the responsibility to make that case has never been stronger. And without deliberate investment, the progress we've made over the last several years has become fragile. And that's why we're asking, along with the Behavioral Health Coalition and BHSB, asking the governor to include a 3% increase for behavioral health providers in his FY27 budget. We're not looking at this as an expansion, but as protection for access and quality. And rates don't exist in a vacuum, and their impact shows up almost most clearly in the workforce. And Dan referenced the 2024 MHCC workforce report, so I'm not going to go into a lot of detail about that. But from the provider perspective, there was nothing in there that we don't see every day. Public behavioral health providers are not just competing with each other for quality staff. They're competing with private practice, telehealth companies, and healthcare sectors that have significantly more financial flexibility. And when providers can't offer competitive wages, predictable increases, recruitment becomes harder and retention becomes almost impossible. And when positions remain vacant, access suffers. Appointments take longer to schedule, caseloads increase for providers, they have fewer options to meet people where they are, and particularly individuals with complex or high acuity needs that frequently are visiting hospitals and emergency rooms. And workforce challenges aren't just about numbers. They're about what kind of care the system is able to deliver. Training new staff requires time, supervision, and experienced clinicians who can mentor and support them, all while the demand continues to grow and acuity within the consumer population increases. And frankly, retention is where quality is most at risk. High turnover disrupts continuity of care, it weakens therapeutic relationships, and it undermines team-based coordinated models of care. And turnover isn't just disruptive for the consumers, it's destabilizing for organizations. Supervisors spend more time onboarding and less time improving care. Clinicians carry heavier caseloads, and quality improvement work gets pushed aside to meet day-to-day demand. With flat funding, many providers were unable to offer salary increases last year. And for many of those, it wasn't the first year without a cost of living adjustment. Burnout is real. And when compensation doesn't keep pace with the demands of the work or the cost of living, even highly committed staff will end up leaving. And when experienced staff leave, organizations lose clinical leadership, supervision capacity, and institutional knowledge. And that directly affects quality, not in theory, but in practice. So when we talk about workforce, we're talking really about whether the system has the stability it needs to deliver consistent, high-quality care over time. And that brings me to a model that is explicitly designed around quality, accountability, and access, and that is certified community behavioral health clinics. So for folks who aren't familiar with CCBHCs, at its core, the CCBHC model establishes a federally defined framework for how community-based behavioral health care should be delivered. And part of why our rates aren't baked in is because we don't have this federal definition of how we do the work that we do. And so for the first time, behavioral health has clear federal definitions for what access, coordination, quality, and accountability are expected to look like in practice. And historically, providers have been asked to do more, serve higher acuity individuals, coordinate access across systems, respond to crises, without a shared definition of what high quality care actually requires. CCBHCs change that by setting clear expectations, not just for what services are offered, but for how care is delivered, measured, and improved over time. In general terms, CCBHCs are expected to provide timely access to care, offer a comprehensive range of mental health and substance use disorder services, coordinate care across systems, collect and report meaningful quality and outcome data, and operate under a payment structure designed to support all of those expectations. And that payment structure matters because it recognizes that quality care requires staffing models, supervision, data infrastructure, and coordination, not just a volume of services. And the value of the CCBHC model is not that every provider will become a CCBHC, and that's not the goal. The value is that it defines what high quality, coordinated behavioral health care looks like, and it aligns financing with that responsibility. And importantly, the model recognizes that quality and access depend on workforce stability. By aligning payments with the scope and intensity of services required, CCBHCs are better positioned to support supervision, training, team-based care, and care coordination. In other words, CCBHCs operationalize many of the things that we talk about abstractly when we're talking about quality. And that framework and those definitions matter when we look at where Maryland is right now in their planning. So Maryland is currently in the planning phase of statewide CCBHC implementation. In 2024, the Department of Health received a federal planning grant and is required to apply for the CCBHC demonstration, which would begin in mid FY27. At the same time, and since about 2018, Maryland has 5 CCBHCs operating under SAMHSA expansion grants, including 3 in and around Baltimore City and Baltimore County. And these clinics are already demonstrating what that model looks like in practice: expanded access, more comprehensive services, and stronger care coordination. They're also providing valuable data and real-world experience that can inform how Maryland approaches the demonstration phase. And the challenge that we're facing now is timing, though. Those expansion grants expire before the demonstration is expected to begin. And that's why we've asked the governor to include bridge funding, not to expand the model prematurely or to require participation, but to protect continuity of care while the state completes its planning and transitions to demonstration. For us, bridge funding is about maintaining access and quality during a defined transition period, so people don't lose services simply because implementation takes time. And so I'm going to close where I started. Reimbursement, workforce, and quality, including models like CCBHCs, are deeply connected. They determine whether Maryland continues to build a strong, stable, high-quality behavioral health system or slowly starts to slide backwards again. This isn't about optimism or alarmism. It's about learning from our history and protecting progress that was hard-fought and hard-won. So again, thank you guys for being here today. Thanks for engaging in this conversation. I know behavioral health policy can be complex, frustrating, and is very slow-moving, but it does matter. And I want to just express appreciation for the time, attention, and effort each one of you brings on behalf of Marylanders living with behavioral health and substance use challenges. Whether you're out there shaping policy, supporting providers, or doing the service delivery of care, thank you so much for the work that you do every day.
Thank you, Nicole.
You're welcome, Adrian.
All right. So I hope now that we've wrapped up our presentations, especially with our last presentation from Nicole, I hope you see there's some alignment between BHSB's policy priorities and those of CBH. And I also want to highlight, and Nicole highlighted this as well, we are both members of the Maryland Behavioral Health Coalition, which is a statewide coalition that advances behavioral health policy in Annapolis as well. All working together on these policy issues, especially in this upcoming session. So we're at the point in time where we can take questions. So as a reminder, please put your questions in the chat. I already see one, and we'll get to that in a second. Please put your questions in the chat, or if you would like to, you can also raise your hand and take yourself off mute. Again, if you're not familiar with Teams, the toolbar at the top has the raise the hand function. You just need to click on that. But before going to questions, I want to just quickly share my screen again and highlight next steps. I just want to do that now before we dive into questions. One, because I don't want to forget, but also because we got some important information that you could be digging into now. So like we said, session starts in a week on January 14th. That means once things get rolling, things are going to get very busy. And I think Dan kind of highlighted the ebbs and flows of the calendar when he was presenting. But to stay informed, to stay connected, we really urge you to sign up for BHSB's policy alerts and follow us on social media. The policy alerts come out frequently during session, and we'll give you an update in particular at crossover, which, as Dan highlighted, is almost the midpoint during session. It's a really important time for when bills you get kind of a signal for when bills are moving forward or may not be moving forward. Also stay informed on social media. We will continue to find ways or promote ways that you can stay engaged, and also promote legislation on your own in partnership with us if that's something you're interested in. There are also 2 advocacy in-person, right? Yeah, advocacy days coming up this session. We're getting in person again. It's still taking a little bit of time, but we've got one coming up in February. This is an overdose prevention advocacy day. This is being organized by the state. What's the office, Dan? Dan, I
The
don't know the best
Maryland
stuff.
Office of Overdose Response, led
Yes.
by Special Secretary Keller.
Yep. So on February 10th at 9 a.m. in Annapolis, please register for that. This is an opportunity if you are involved with overdose prevention, if you're involved with harm reduction work, to come to Annapolis and elevate this work and make it very visible. Relatedly, also later that month, get involved with the Keep the Door Open rally. This is organized by the Mental Health Association of Maryland, which convenes the coalition. We get hundreds of advocates and providers and consumers that come down to Annapolis, again, to be visible and promote our collective policy priorities. So please, please stay involved. So I see we've got hands raised and questions in the chat. I am going to start with the first question I saw in the chat. I think, Nicole, this is for you, and is around, is a CCBHC similar to a psychiatric rehabilitation program? Could you just make a distinction there?
Sure. Yeah. Thanks for the question, Kelly. Similar, yes, but they're really designed more toward outpatient mental health clinics. And so I will say that the 5 CCBHCs we have operating here in Maryland also have PRP as a component. But really, the CCBHC, the funding model is really designed towards more of the outpatient mental health clinic services. CCBHCs are required to provide 9 service categories, and those include crisis mental health services, so they have to be available 24/7. They have to do screening, diagnosis and assessment, patient-centered treatment planning, outpatient substance use services, mental health services. They also have to be connected with outpatient primary care, targeted case management. They do have psych rehab as part of that. It's not the only part of that. Peer support and family services and military and veteran services. So PRPs are a part of the model, but they are not the whole model, if that helps.
Thank you.
Thank you so much.
Of course.
I've got one other question in the chat. I'm going to try to take this one quickly. So this is from Mars, about behavioral health workforce and licensing. So the General Assembly is not planning to make any changes to licensing for behavioral health programs. That is overseen by the Behavioral Health Administration. They are looking to make some changes through COMAR, which has been an ongoing process. So that is where those changes would be made. But relatedly, yes, it can affect workforce.
And real quick, Adrian, I think Mars is also asking about licensure for professionals, and
Yes.
And that we're hoping that it's going to be some relaxing, like to address the workforce shortage. We want it to be easier for folks to qualify for different licensure, not more difficult. But except like, they're not going to be dramatic changes, but some of the stuff that passed, like in years past, were kind of reciprocity bills, where if you were licensed in one state, it would count here in Maryland, or other ways to simplify the process of getting a license to practice.
Thanks, Dan.
Thank you.
Next, I'm going to go to hands that I see raised. First, I see Jacqueline. Feel free to take yourself off mute.
Good morning, and thank you for this forum. I have so many questions. I'm going to try to put them together in one. And these questions are directed to Dan. Thank you for the information in which you had given. You spoke about promoting, ensuring, strengthening, increased implementation, and maximizing. As a licensed provider under the sub arena, I'm finding it very, very challenging when it comes to consumers and their barriers, their housing barriers. And you said that you guys are going to be bridging that gap. How do you plan to bridge that gap? We are the first substance abuse program that offer the 811 housing. We have a navigator, on-site navigator, and we have met so many barriers. We do exactly what's required of us. We make sure all documentation is submitted in a timely manner. And that might be a local question as to why that's happening. But for you, Dan, how are we bridging the gap with more affordable housing? What does that look like is one question. And then my other question on top of that is, how do you plan to remedy this may be a BHA question, I mean a Medicaid question, payments in a timely manner, authorizations, submissions. I don't know if we spoke about that. The time frame, how are we able to be productive as providers when there's such a long gap for authorizations to be approved, and we got to go through so much, and then when we call and we contact the powers that be, no one can answer the questions. How do we plan to bridge the communication gap from providers to various agencies, providers and trainings? Where is the training for trauma informed? I've been looking for trauma informed training for staff for the last 30 days and have not been successful. I was told to contact Baltimore City Police Department. Nobody knows how to get me some trauma informed. So there's a lot of gaps that need to be bridged.
So Jacqueline, I'm just gonna chime in here. I'll let Dan answer the first part of your question, but then we will follow up with some of these other things that I heard related to the trauma informed care. We have a provider relations manager who will follow up with you. Can you put your information in the chat just so we have it easily accessible? But Dan, do you want to take the first part of her question?
Yeah, absolutely. Housing is so critical. This is a newish area for BHSB. This has not traditionally been one of our priorities. So we will probably look to partners of ours. Healthcare for the Homeless is one of our strongest partners when it comes to housing. But we want to see housing options expand, and we definitely don't want to see them shrink. Some of the ways that we hope to see them expand is there is a program called ACES, Assistance and Community Integration Services, I believe is the acronym. And that is a program through Medicaid that provides permanent supportive housing. We want to see that increase, and we want to work with the governor and the General Assembly to see that increase. Recovery housing is another area where we want to see high quality recovery housing increase and make sure that the dollars that are spent are being spent on good programs and on programs that provide like the most affordable and stable housing as we can for the resources that we have. And the Section 811 program that you mentioned, the funding comes from the feds and then it's administered locally, things of that sort. We're going to keep our eye on it. We're worried that HUD is under pressure at the federal level. The current federal administration proposed gigantic cuts to HUD, and so we'll be following that and trying to prevent that and hopefully increase federal resources for housing. So there's a couple ideas, and we look forward to working with anyone else who's in the space.
Thanks, Dan. So we are at about 4 minutes left. I'm going to go to Logan, and then there's a question in the chat around Medicaid. We'll do that. So those are our next two questions. If we have time for more after that, we will do it. I also see some questions in the chat that we can answer through the chat, so we'll respond to those as well. But next, let's go to Logan.
Yeah, thanks. Logan Hollinger. I'm an independent journalist here in Baltimore. I had a question about the updated SAMHSA guidance and how that may impact harm reduction policy in the state. I know that right now it seems like it's more so a matter of semantics. For example, state, I feel like, if I remember correctly, the Access Grant Program has basically scrubbed any mention of the term harm reduction. And it seems that existing policies that are already legal may not be under threat. But it does seem to have some sort of chilling effect on maybe more ambitious policies that are have been fought for in the past, such as OPCs. I know at the state level, OPCs didn't really have much of a chance under Bill Ferguson. And I know that's not being introduced this year, but at the city level, for example, we're seeing basically a complete withdrawal of any chance of OPCs locally. So I just wanted to ask, are there concerns about the updated federal guidance on harm reduction policy as it pertains to state legislation and funding for existing programs?
Yeah, I can
Thanks
start.
for that.
Oh, Go ahead, Dan.
Yeah, thanks for that, Logan. I mean, I think a lot of the concerns that you raised are like we share. It sounds like you're pretty well versed in it. We are concerned about the executive order in question in the SAMHSA guidance that has come out, but we're continuing to advocate for the same policies that we have always advocated for, and to support evidence-based harm reduction programs in the state, so, and in the city. So we're continuing to do the work as we always have, and but it is concerning to see that sort of language come out of the from the federal government.
Thanks, Dan. Lisa, I think this next one is for you. I don't know if you saw it, it was in the chat. In regards to Medicaid, is there going to be any work touching on the various obstacles for increasing the needs for placement in specialized nursing care upon hospital discharge for people who use drugs?
I will have to take that one back to some of our behavioral health colleagues, Adrian. I'm afraid I'm not prepared to address that on this call.
Okay. Problem. We've got another Medicaid one, though. I don't know if you also saw this one. So this is around the, I don't know how you print ACIS. I don't remember what ACEs. I don't remember what that stands for. I know it's housing related. And it's their understanding that MDH must apply by October 1st, 2025 for a federal waiver to provide supportive housing and health services under Medicaid. Considering the Medicaid changes that ACEs, and that ACEs was a hot topic last year, is this expected to continue as a legislative priority in 2026?
So I can't speak to the legislative priority component of it, but the ACEs program is authorized under our 1115 waiver and has been, I believe, since 2021. We did get granted an expansion in terms of the number of slots from 900 to, I believe, just over 2,000 at the start of 2025. And ACEs continues to be included as part of our 1115 demonstration renewal application to CMS. Our current authority expires at the end of this calendar year, and we've requested ongoing authority for that effective in January of 2027. Our amendment request is for a 5-year extension. So the department has requested federal authority to continue that program. I did want to clarify, and I put this in the chat, that program, Medicaid generally is barred from paying for room and board or rent directly. So in Maryland, our iteration of the program does not pay for those services, but it is a pathway to housing and a pathway to keeping people in housing. And I've included some additional background on that. The link I provided in the chat. So Cindy, you can see some of the background on that program. And I'm happy if you want to share contact information with Adrian to connect you with the individuals that help operate that. We are in the process of getting ready to stand up a competitive process for expansion to fill those additional slots. You can see in the link that I provided the areas of the state where it's in operation today, but there's an opportunity for us to expand. And we've shifted the payment model from a grant-based model to more of a traditional reimbursement provider enrolled model. So ACEs is very much alive and well and supported by the department, included in our budget planning.
Great, thank you. Well, we are at time. So I just want to take a moment to thank our presenters for joining us today. Thank all of you for joining us today as well. As a reminder, please stay in touch. Please stay engaged with us throughout this legislative session. For those of you who had questions in the chat that weren't addressed, we will follow up and address your questions. We have a copy of them, so please keep an eye out. As I mentioned earlier, we will follow up with the slides, the recording, answers to your questions, so keep an eye on your email. And again, thank you for joining us today, and we look forward to working with so many of you in the next several months as we navigate our priorities through the legislative session.